Good morning. Welcome to Grand Rounds. It's March 22nd. I'm Jan Dick, and we have a great program today. We have a series of speakers. Before I hand it to Dr. Sun to introduce our speakers, I'd like to thank AstraZeneca, who's here sponsoring us today, and they're here in person, Jeff Sandvig and Sean McCulley. And then, John, I'm sure there's a link, if you aren't here today, that you can pop on and have a chat with them as well. So Dr. Sun, let's get going. Thanks for being here.
Thank you. Good morning. It is my pleasure to introduce my two close colleagues and friends in the heart failure arena to talk about Frankenstein's monster, the new approaches to organ procurement that many of you have witnessed, or been part of, or certainly been exposed to in the local media. First up will be Dr. Bassam Shukrallah. Sammy comes by the way of Texas, where he did his undergraduate training and then subsequently worked his way off to Southern Alabama to do his general surgery training. And I don't know what happened that he got up into the cold north to the University of Minnesota, where he did his cardiac training. We had the opportunity to interact with him during those years. He went down to Ohio State, where he was on faculty before we were able to recruit him back. He's been a critical component of our heart failure program and really is the one who's doing a lot of the heavy leg lifts for the OCS system. Sammy's going to speak first for about 20 minutes and then take some questions and run to the operating room, and then this will be followed by Karol Mudy. Karol, who also most of you know, he comes by way of Poland, worked his way through Philadelphia for his general surgery training, and then also up into the great north in Minneapolis for his cardiac training at the University of Minnesota, and we've had the pleasure of working with him since his graduation and hire. So our two big pillars of our heart failure and mechanical circulatory support will be speaking. Thank you. Sammy.
Is this good? Good morning, everybody. After our second DCD heart transplant, Ben made the comment that if you told them 10 to 15 years ago that we'll be allowing the heart to die and then resuscitating and implanting in someone, and he'd call you crazy or nuts. So this is how I came up with, Frankenstein comes to Abbott, a heart failure talk. And Karol will be going over some of our results and some of the studies and some literature that's available for this novel therapy. And I'll kind of be describing a few things. I'm going to go over in detail what OCS is. This has come by popular demand by some of the people that have asked me to give this talk. They want to know how this works, how blood flows through the heart, how we monitor it, etc. And in both the articles and the TV presentation that happened recently, it was my impression, I'm not sure if it was yours, but the concept of DCD, death after circulatory death, was kind of lost. And it's very important for us to understand what DCD is and why this system enables us to transplant hearts when it comes to death after circulatory death. I'm going to go over death after brain death and death after circulatory death, so you'll have a clear understanding of it, and then we'll talk about the data. It's just very, very important to me to really highlight the work that Transmedic has done. This gentleman is an immigrant from, his name is Walid Hassanein. I think I did that right. I'm from that area of the world. I'm surprised I'm struggling, but anyway. But he's the innovator behind it. He was completing his training at Georgetown, where he left for 2 years to the Brigham to do some heart failure research, and it was there that he was exposed to heart transplantation, found that the heart was preserved on ice, and was wondering how that heart is put on ice and transplanted. He wanted to do something different, so he began to develop preservation of the heart using blood, and submitted his landmark article in 1998 to the JCVTS. I'll very quickly go over that. They basically broke it down into two groups. One group, he arrested the heart and they put it on ice, followed him over 12 hours. The other group, he preserved the heart with the blood that was taken from. So, sorry, let me back up. They took swine. They took 49 swine, they divided them into two groups. The first group, they preserved them using ice, which means they arrested the heart and put it on ice for 12 hours. The second group, they preserved it with the swine's blood. And from there, they connected it to this model that will eventually mirror, will be the precursor to the OCS device. And essentially, they had a cannula that was placed in the aorta that delivered the blood. They closed off the SVC and IVC, and then they put a cannula in the pulmonary artery. And as you can imagine, as blood comes through the aorta, there's a competent aortic valve. The blood then flows through the coronaries, empties out through the sinus, and comes back to the right side of the heart. Well, the right side of the heart is closed. The SVC and IVC is closed, so it exits through the right ventricle and pulmonary artery. And therefore, you can measure coronary flow that way. And then they had direct probes that were placed on the aorta and pulmonary artery that measured pressures for them. The last thing they measured was that pH. They put a probe on the posterior aspect of the heart and measured pH. And what they found, that the top line, as you can see, this top line is the blood preserved heart. And you can see the pH is steady state through the 12 hours. In the cold preserved heart, the acidosis occurred as you would imagine that it would when you put the heart on ice. But even after reanimating this heart or reperfusing it, it never really came back to where the blood preservation was. And then you also look at pressures. So they measured all these measurements 2 hours after when they took it off ice, represerved it. They took measurements over those 2 hours, and that's what you saw. The pH kind of cycled back up, but didn't meet what the cold preserved time. And this I found very interesting, that at 1 hour, the pressure that they measured in the ventricle were similar, but at 2 hours, they were quite different. The bottom line would be your ice group. The top line would be your blood preserved group. So it led them, they measured other things. I'm not going to get into it so we can speed through this, but this first allowed them to address the time issue. They started thinking that if we can preserve this heart with blood over this amount of time, this is going to allow us to start to deal with the time issue. Because, hearts, if you go, there's some variation. Ben may transplant a heart more than 4 hours. I would struggle to transplant a heart after 4 hours on ice. Time is an issue with transplantation. After you get to that 4th hour, you have to start becoming concerned about the heart. But with cold preserved hearts, you can see that they remain steady state over a prolonged period of time, certainly exceeding 6 hours. So with that landmark article, after that landmark article came out, they began to develop this organ care system. And what is it? Well, it's a portable integrated perfusion system, and it has 3 components to it. One, it has this module, and this is where we put the heart. I'll show you this in much greater detail, but this is kind of looking at it from a mile high. This module, we connect the heart to it, and it interacts with the software, with the solutions, and with this monitor right here that you see. So this is kind of the brain of the system, or not the brain of the system. It's kind of like the nuts and bolts. It's the main thing for it. Then there's a solution set that has substrates and medication that are infused into the circuit. And then we get to control everything with this wireless monitor. I'm sorry, this wireless monitor allows us to observe what's going on with the organ. It also allows us to infuse medication. It's all computerized and wireless. So it kind of looks like that. Over here, you can see these. You see this one here, and I think I have a better picture here. These are there's an array of non-invasive ultrasound guided monitors. You can see them here, here, and here. This is for the pulmonary artery, or the pulmonary artery will have, pulmonary cannula will have one, the aorta will have one. So it allows us to measure pressures in these areas. The solution set here that you saw prior, this solution set here, this is connected to these, I'll keep pointing with my finger, I'm sorry, to these two cartridges, and they all communicate with that wireless device that we have with the monitor. So if we need more medication, we just dial it up on that. And if we need to turn down coronary or the flow of the pump, we do it with this monitor. So it allows us a complete control of what we need to do to the heart via medications and/or blood flow. So that's kind of the system and what it has and what its components are like, and where and the background of where it came from. Let's switch gears and talk about death after brain death versus death after circulatory death, DBD and DCD. What are the differences between the same injury? You have a devastating head injury on both of them. The next thing we look at is, do you meet brain death criteria? And this is a very stringent criteria that's come out. If you meet brain death criteria, then you are legally dead. You're just a body holding organs. If you do not meet brain death criteria, then you are what we would consider, then you would be the DCD, the patient that can undergo DCD, which means, let's just backtrack a little bit. Let me make it a little bit more clear. If you meet brain death criteria, you're legally you're pronounced dead, but you're just a body holding organ, meaning your pressures are fine, you're stable. If you don't meet those criteria, then a determination has to be made. Let's make that distinction. If you are the DBD, you're a donor and you're a suitable donor, et cetera, you go towards donation. If, however, you're a patient that does not meet the brain death criteria but have a devastating head injury, the family can then be approached to see if you would consider donation. And that's what we mean by DCD donation. It is a person that has a devastating head injury that has some residual brainstem activity. So he does not meet the legal definition of brain death. At that point, if the family decides that they do want to pursue donation, the patient's taken to the operating room where life-supporting measures are withdrawn, and if they pass within a certain period of time that's allocated for each organ, then procurement can occur. Now, DCD donation has been widely applied to all organs except the heart. The reason is we could not evaluate what happens during warm ischemia time, and I'll explain to you why that is. So if you look at column A, this is a DBD patient that's going for procurement. As you can, everywhere you see blue, that's ischemia. So if we look here on the DBD donation, you are taken to the operating room in a controlled fashion. There's no warm ischemia time associated with DBD donors. You go to the operating room, you take it, we open, we cross clamp, we immediately arrest the heart and procure it and put it on ice and or the OCS device. However, on the DCD hearts, there's an aspect of warm ischemia. And then let's look here. You withdraw care here. The patient still has pressure. His pressure may be 50 over 30 for X amount of time. This could last for up to, you can have this kind of pressure for hours. Or you could be 80 over 20 or 50 over 30. So this is what we would call warm ischemias. After we withdraw care and your pressure softened and your saturations are lower than a certain set point, but you still have activity, you're not declared dead. You are declared dead when you have no activity, when you're flatline and pulse, you have no activity. And that is stipulated by by the federal government, the criteria that we use, and that is determined by not us, but is determined by the local hospital staff. They determine if the patient has passed. After that, there's also an additional 5 minutes that we have to wait. So all this time that waiting, the heart hasn't been touched. It's been enduring low pressures, and then 5 minutes of no pressure at all. So because of that, we haven't been able to use hearts because of this warm ischemia, because we had no way of evaluating it. So with the advent of this OCS, there was, again, this inertia to re-examine the capability of procuring hearts from DCD donors. And indeed, the group in Australia was the first to do that. In 2014, I remember I was a fellow here, and we heard it through a newspaper that it happened. But they have done just a yeoman's work with this. Carl's going to go over this in greater detail, but very quickly, these folks, over 5 centers, have transplanted 23 hearts. They've had 45 DCD donors, 33 which they eventually went and procured. There was, I think, 6 or 7 that were not usable up front, but they used it in 23 patients with 1 death. I want you to keep this 1 death in mind as we kind of progress towards the end. But it's just fantastic results across the board that they saw. They did have a higher utilization of mechanical support in the DCD arm of their transplantation, and that was also seen across centers that are doing it, and including us. The second, and really the elephant in the room, is what's happening at Papworth. I mean, they have 80 hearts. They just reported 79, but who's counting? But the interesting thing at Papworth is that they have a little nuance on how they're doing the DCD hearts, but it's beyond the scope of this presentation. But I just want I want to highlight a few things, and I don't want to steal Carl's thunder. These folks increased their transplantation by nearly 50%. I mean, that's just I don't know what to say about that. It's just incredible. And with 30-day and 1-year mortality rate, exactly the same as their non-DCD hearts. So we're going to switch gears. I'm going to take you into the operating room with me and tell you, how's this done, what does it look like. So the way I look at DBD and DCD, DBD procurement is a very choreographed event. You go in, it's very controlled, everybody's holding hands and singing hymns. The DCD is the exact opposite of that. It looks much like, if you've ever seen a car race, a Formula One race, I encourage you, if you're bored with racing, as some are, this is the most exciting part of the race. There's a purr to everything, there's complete silence, and there's a tension in the air. And when the green light goes off, it doesn't look like a straight line anymore like that. it looks more like this. They're all rushing, and this is what DCD is. When they tell you to go, all teams, well, not all teams, we'll get to that in a minute, but we all are rushing to get there. So let me just kind of remind you. DBD, like we said, it looks like a symphony. DCD, it gets to be a little more chaotic. Why is that? Again, I remind you, there is a period where we withdraw care, and then there's this warm ischemia, this functional warm ischemia, until the person is determined that he has died. This period here is when all the cars are idling. You know, there's a lot of tension in the air. And in our particular study, we have 30 minutes for this to occur. After that, we cannot use the heart. And this is our study that we're involved with. If your systolic blood pressure reaches 50 and saturations are below 70, the time clock starts in this warm ischemia. So you have to pass within 30 minutes. The reason I put lung, kidney, and liver, they kind of mirror both because we need them to behave early on. And what do I mean by that? From our heart perspective, we have to drain 1.5 liters of blood before anyone else touches perfuses their organs. So it's really a testament of the other team's willingness to work with us. I have to just say a big thank you to them because they are enduring longer warm ischemia time for their organs when they really don't need to. But they allow us to do this. So we have to drain 1 liter of blood. I'm sorry, 1.5 liters of blood. And usually we set up our equipment, our own. We put it up top. We make an incision into the right atrium, put a cannula in, and pass this bag that goes to the floor, and we siphon 1.5 liters. As soon as this siphon happens, everybody starts flushing their organs, including us. So we flush the heart with cardioplegia, and then we vent it on the right and the left. And then the procurement happens. Excuse me. Let's see here. How do you move back? Let's see here. There we go. So the procurement happens. There's cut lines across the aorta, pulmonary artery, the IVC, SVC. Then we flip the heart over and cut across the left atrium. Once that happens, we take the heart to the back table and put 3 cannulas and close it in two places. So we put the aortic cannula in first and secure it with a zip tie. Then we put the pulmonary artery cannula in. We put an LV vent in. And this LV vent just passively drains into this canister. And then we close the SVC and IVC. And how does blood flow? Blood comes into the aorta again. You have a competent aortic valve, goes down the coronaries, drains into the coronary sinus. The coronary sinus drains into the atrium. And because you've closed off your SVC and IVC, the blood just continues to go up into the pulmonary artery. This allows you to measure coronary flow. This allows you to measure aortic flows and aortic pressures. These 3 highlighted things that I show that we monitor all these, but these 3 are the ones that we manipulate most to set up the organ for transplantation. So how does this occur? The organ has been placed on the OCS system, and then once that is done, is connected to all these monitors that the module has. We begin to monitor. As you can see here, it shows you your aortic blood pressure, your flow, aortic flow, and your coronary flow. And we like things to be in these ranges, and we manipulate the flow, or we give it adenosine, or we give it various medications to manipulate blood pressure, to manipulate coronary flow, and it's all about.
Sammy, is it beating during this time?
Yes.
Okay.
Yes, the heart is beating, and you'll see it here in a minute. And then secondly, we start sampling the blood from the arterial side and the venous side, and we like to see a separation with the lactates. So we like, for example, if your aortic lactate is 3, 0.1, we like your venous lactate to be 2.9. So we have this nice separation of the lactates. So this is the most recent DCD heart that we did, and as you can see, the heart looks very nice. It's being paced. These are pacing wires that we have on it. This is the pulmonary artery, and this is our LV vent. And then we look at the monitor here, and it shows you your coronary flow is 8, your aortic pressure is 74. I mean, all within the parameters. This heart looks fantastic. I didn't have the rest of the lactates, but you can see the lactates nicely separated. This heart was accepted and transplanted and did well. I think he had to be recovered on ECMO for a few days, but has done well since. This is the heart that I procured over the weekend, and it's a heart that's misbehaving. It's a heart that's not, you can look just morphologically its function. It's not as snappy as the previous heart. And this is what alarmed us the most with this. Look at your pressure. These pressures were much higher right here. The pressure was 170 over 129. Your coronary flow was 0.5. I mean, if you had this, your coronary flow should be, like 2 liters or higher. But there's a huge discrepancy there. So we immediately looked into it to make sure there's no dissection, there's no mechanical thing. We're unsure of what the true cause of what's going on with this heart. The point I'm trying to make is this machine allowed us to examine a heart that came from Sacramento, California, which required a refuel, which would have never happened if we didn't have this device. But the interesting thing about this is the device allowed you to make an evaluation of this organ, and we declined this heart. So it's just to show you the two types of ways we've used the machine. And there's really no clear rhyme or reason of which hearts are going to do well and which hearts aren't. I was going to tell you about the death that happened in Australia. The heart had extremely short warm ischemic time, was procured well, patient didn't have a VAD. I mean, it was the most perfect scenario, much like it was the most perfect scenario in California. But because of what we've learned from them and what they've really done a yeoman's work of how to evaluate this heart, we were able to evaluate this heart and say, this is not going to be suitable for transplant. Anyhow.
So is the pressures just dictated by the coronary vascular resistance?
Yes, essentially.
So even given vasodilators, you're unable to bring that?
Couldn't bring it down.
So is it like
100 we gave.
Obstruction issue then, or?
Correct.
Yes.
This is your target circulation basically. So coronary flow is really this is the only vessels that this system has. So vasodilator that is is in maintenance solution, which is adenosine, is given to vasodilate at the capillary level, and you observe the coronary flow in relation to aortic flow, and it's dictated by those two things: aortic pressure and the vasodilation by the preservation.
What was you monitor LVADP, right? You have a vent in the LV. Oh, no.
It's a decompressed state.
Just to decompress the LV.
The LV is not working. We're not measuring the work. In fact, the first iteration of this device many years ago was loaded. So it was a loaded heart. So they actually had, blood in it so that you were measuring that. The problem is the complexity of maintaining that in transit was so high that they decided to take that component of it off of it and just focus on a rested, unloaded heart.
Yeah.
So you don't evaluate coronaries in any way before?
Well, they did an angiogram they do angiograms if we're at all concerned, and we did an angiogram on this lady. The EF on it was normal. The Australian group EF was completely normal. So
this is multifactorial means,
Yeah.
right? This can't be one. So the other question comes to mind is, usually speaking, in 70 years, right, what we have learned is rested heart is better than the beating heart. So this is slightly a different concept now. So this is, you are talking of, heart which is already beating, which has consumption.
Yes,
So-
yes, you're right, but it's also, it's beating, but it's not loaded, right?
Sure.
So that's the idea. Now, before, when we're taking hearts, we have to take what we call, a perfect all parameters heart, because we're throwing on ice, we don't really know what's happening to it until we basically take it, sew it in and take it out. Now, we're taking hearts that otherwise would not have been taken. We're putting on this device, we're actually assessing it to see if it will be, meet the criteria that we think would make a good transplant. And so that opens the door for so many other hearts that we had not used. So that's the important part. Now, we're gonna be learning, this is a platform so that we can learn. Right now, we're using lactate as our only kind of surrogate. Beyond the flows and the pressure, we're using that as the only physiologic marker. But there are other physiologic markers that we can probably add to the monitoring of this device, of this heart, to get a better fidelity of what's gonna happen as we move forward.
Means, I think the approach has been, you missed a step in the whole process, right? So you have brain dead donors, classic heart transplantation. You're throwing the heart which is you are happy with before, accepting it. And then you transfer it arrested on the ice. And now we have missed a step in between to apply this concept of transmedics to actually those kind of hearts and see if you can extend that for
no,
our
We are.
We are.
Yeah,
too. Yeah.
because now we are taking patients who you don't know what has happened, like,
Right.
and now you're trying to resuscitate these
Right,
hearts.
but there are two studies here, right? One of them is.
I'll be
the-
happy to talk
Yeah,
about it.
and Carl's gonna talk about it, but there are two sides. There is the intermediate, which is what, it's called the expand trial, and that went first before the DCD. We kind of jumped to the end because it's much more exciting, but the expand is also expanding the pool, and
Yeah.
Carl will be talking about it.
Thank you, Sammy. Good morning, everybody. I will give, I'll jump into the more boring part, which is the update on current OCS studies that MHI is part of, and give you the update from the country and some reports from around the world. Our disclosure since we last met last year with the audience here didn't change, which basically means that both of us are still quite poor. Let's get back quickly to expand trial, which is the first IDE trial. This was a single-arm study, which we were part of. The results were reported in 2019. This was the utilization and results of the extended donor heart criteria. Again, as I mentioned, single-arm study with hearts that normally would not be utilized for transplantation because of the either increased ischemic donor time, i.e. distance, also older donor age, as well as increased downtime, left ventricular hypertrophy, and non-specific coronary disease. So any of those criteria or many of those criteria could be used to make the donor eligible for the enrollment. The primary endpoint of the study was a composite of patient survival at 30 days and severe primary graft dysfunction at 24 hours. Secondary endpoint was the utilization heart rate. The safety endpoint was the either moderate or severe primary graft dysfunction at 1 month. This is the breakdown of the heart that were recovered and perfused on OCS. Out of 93 hearts recovered, 81% were utilized, so 75 hearts were implanted, 18 did not meet criteria for transplantation. This is the breakdown of the time outside the body, where we can see the upfront so-called cold ischemic time, which is the time from the cross clamp and cold flush in the human body, then instrumentation and time on the organ care system, and at the tail end we have a mean of 72 minutes of the warm ischemic time, which is the time from the final cold flush from the device and till the cross clamp in the recipient body is taken off the aorta and heart is reperfused. So this is two different ischemic times cold and warm.
Carl, can I interrupt 1 second? This study is done on donor after brain death. So these are brain death studies.
Not
Before
surgery.
this is the intermediate, huge group that looks at people that are higher risk for traditional
We're trying
transplant.
to expand
That's
it
what
over,
this
yeah,
is, yeah.
yeah.
Total time outside the body in the trial was about 380 minutes with total ischemic time, cold and warm, of about 102 minutes. At 24 hours, moderate or severe primary graft dysfunction at 15%, with severe graft dysfunction at 10%, which was comparable to a normal standard donor criteria on DBD patients, with excellent 95% survival at 1 month. And the trial met its safety and effectiveness criteria. And this is kind of the gate for us on DBD population and hopefully ability to expand the donor pool among traditionally donated heart, meaning after brain death. Continued access protocol on the expand immediately followed. So FDA was approached to allow us accrue more patients and enroll to the single arm registry in order to get more information and experience on this strategy, and also to bridge the time between the final results are fully reported and until the FDA approves it for commercial use. The design of the trial is very similar. So extended ischemic time over 4 hours as a main eligibility donor criteria, or extended ischemic time over 2 hours, plus one of the increased risk for PGD, primary graft dysfunction, features that are listed here, as you can see. The endpoint of the CAP is the same primary endpoint, which is the composite of 1 month survival and the primary graft dysfunction, severe primary graft dysfunction at 24 hours. And secondary endpoint also similar, which is the heart utilization rate, as well as patient survival at 1 month and incidence of primary graft dysfunction, right or left. The safety endpoint is the moderate or severe primary graft dysfunction at 1 month, so same criteria, and also primary graft failure requiring transplantation. So this is the update from the country so far. 66 extended criteria hearts have been transplanted across 6 sites. Altogether, there is 15 sites that are participating. There are still 9 remaining enrollment spots that so far didn't participate. There have been 4 hearts on this trial that have been declined, which resulted altogether, as you can see, in utilization of 94%. So IDE trial 81, 94% in the continued access protocol, which basically shows that majority of centers that are participating and enrolling are more encouraged by the technology and clearly trusting this process. More than 45% of all patients enrolled were on preoperative mechanical circulatory support. This is, more than 45% met more than 1 inclusion criteria, so not just the distance, but other high-risk features. More than 45% had preoperative MCS, and the hemodynamic data collected from the OCS is listed here, which is the mean aortic pressure of 78, coronary flow, which is smack in the middle where we want it, and average time, average perfusion time on the device was 4.5 hours, with the longest so far at 446 minutes. So far in the CAP, we have 100% survival at 1 month and severe primary graft dysfunction lower than 10%, which is completely comparable to donation after, to the standard donor criteria within the DBD pool. At MHI, we enrolled 6 patients between August of 2019 and January of 2021. We had 100% utilization rate. We had 6 runs and 6 transplants. We did not have severe primary graft dysfunction, so no need for postoperative mechanical circulatory support. all our patients are alive so far, and 66% of them had preoperative LVADs. I'm gonna switch gears now and go to the donation after circulatory death. We cannot talk about DCD patients without mentioning the Papworth paper that Sami alluded to. I'm just gonna very briefly present it. This was 28 DCD hearts that were done in United Kingdom by Dr. Messer and his group. The strategy, how they recover the hearts from the donor body is slightly different. They have two different techniques, which is the direct procurement and perfusion, DPP. This is something that also is approved and exercised by us here in the United States. And they also do something that is called normothermic regional perfusion, where basically the preservation solution is infused in the donor body, but that's something that is unique to United Kingdom, and we will not be discussing it in more details. Patients that were transplanted in a DCD group then were compared with a historical cohort, which was the donation after brain death patients that were matched for donor and recipient characteristics. As you can see, the main inclusion criteria that I just want to mention, so this is clear, it's a category 3 Maastricht donor type, which means they don't meet brain death criteria. There is brainstem function. They need the life supporting measures have to be withdrawn, and the death has to occur based on the circulatory criteria, meaning the heart has to stop, there has to be no pulse, no blood pressure. In terms of the results of that trial, let's focus on this column on the left side, DCD versus DBD, survival at 1 month and 90 months, no difference. In terms of the hemodynamics, DCD, there is improved cardiac index, cardiac output, so slightly better hemodynamics. As we can see, they were statistically significantly different, but clinically there was no difference. Similar need for mechanical circulatory support of any type. Slightly better again on the DCD in terms of the need for inotropes. However, clinically, as we can see, this is not significant. Post-transplant outcomes in terms of the time on the ventilator or length of stay similar, with some signal, as we can see, on hospital stay improved on the DCD side, but overall very similar results between the DCD and the DBD group. When we look at survival at 3 months in this cohort, we see no statistical difference between the DCD and DBD, as well as 1 year survival between DCD and DBD, 86 versus 88. So excellent results at 1 month, 3 months, and 1 year in this 28 DCD heart group. The same group just reported a 5-year experience. This is they continued the study for remaining time until recently. This was reported last year. Again, something that Sami mentioned before. During the 5-year study, the DCD strategy increased the overall transplant activity by 48%. So this is really groundbreaking information. This is a very Royal Papworth Hospital is a very aggressive transplantation program, but overall this is observed across the world, increasing transplant activity, something that we're hoping to achieve obviously in United States here at MHI and everywhere else to provide for our patients on the wait list. When those patients that were transplanted with the DCD strategy were compared to DBD, 79 donation after circulatory death versus 164 after brain death, they had the same 30-day survival, 1 year survival, and same post-operative hospital stay. And again, the trial concluded that donation after circulatory death is safe with the same result in terms of the survival. What also is very important, it increased the transplant activity by half. We can see breakdown between the DBD and DCD, increasing percentage of heart that are recovered after circulatory death, similar survival, at 1 year, 12 months here, and 5 years. We can see that the trend remains. Those hearts don't degenerate faster, they're not rejected faster, they're basically the same quality. Australian experience, in a way, a little unique because of the geographic structure of the country. The centers are very much remote from each other. This is their experience over a few years, where they recovered 33 DCD hearts from 45 donors, which means that 12 donors of this group did not progress to circulatory death, so patients did not expire after withdrawal of life-supporting measures. And out of those 33 recovered hearts, 23 were transplanted, which means that remaining 11 did not meet criteria for implantation. 9 of them, nine of those hearts did not perform well on OCS, and that's why they were turned down. And they had two runs with malfunction of the OCS itself, and for that reason, those hearts were not utilized. Out of 23 hearts that were transplanted, 1 patient died, which overall resulted in 4.4% mortality rate at 4 years. What they observed was a higher rate of mechanical circulatory support need in the perioperative time, which means 9 cases out of 23 cases required short run of mechanical circulatory support, i.e. ECMO in majority of cases. But what they noticed, patients that once they were weaned of mechanical circulatory support had the same 1 month and 1 year and 4 year survival. So again, we can see here Kaplan-Meier curves for survival at 4 years, no statistical difference between the DCD, which is the top, and DBD hearts. So again, similar observed survival rate and patient's performance and organ performance after DCD donation. In terms of our trial that we are participating, this is a randomized control trial where patients are enrolled to either arm where the DCD is possible or standard of care is the only option. So the randomization happens in 3-to-1 ratio. As we can see, this arm where the DCD is possible also has standard of care heart, which means we don't want to give patients disadvantage of not being eligible for preservation on ice. And there is another arm where the only standard of care is available, and those hearts then are compared between the DCD and standard of care, 2 cohorts from this arm only or DCD possible to SOC group here. In terms of participating sites, there's 15 participating sites in the country. Initial design of the trial was to have 53 transplanted DCD hearts versus 155 standard of care. This was actually reappealed to FDA pretty quickly because it turned out that majority of centers that participate in the trial are very much braver than FDA expected, and it was very obvious that enrollment of DCD hearts was much faster comparing to standard of care, and the number of patients was then readjusted to 90 versus 90, so 90 versus 90. Again, inclusion criteria, Maastricht category 3, DCD donor, and this is just specifics of hemodynamic time measurements and warm ischemic time in the donor body after withdrawal of life-supporting measures. This is a non-inferiority pivotal trial where we're comparing the survival of the patient at 6 months as a primary endpoint. Secondary endpoint is the heart utilization rate and severe primary graft dysfunction of the donated heart. In terms of what's happening, what happened with the numbers in the DCD IDE trial, the enrollment is at this point closed. All 90 hearts in DCD group are enrolled, and they were transplanted by altogether 9 sites. So this is the initial 53 that was then extended to 90. and this was then transplanted against 90 heart enrolled in the standard of care, which was the cold preservation arm. 11 hearts were declined after the OCS run, which resulted in 89% utilization rate. In terms of the recipient MCS support, and was very similar to expand continued access protocols. I'm just going to remind, this was about 45% of patients receiving DCD hearts were on previous preoperative mechanical circulatory support, i.e. LVAD. This is the hemodynamics from the DCD trial. As we can see, very similar parameters that to expand trial. So those hearts after circulatory death performing very similar on the device to DBD hearts, and primary graft dysfunction and survival at this point cannot be reported yet from the trial because this is in process of being reviewed by FDA. But after my conversation with the trial sponsor, everybody is very encouraged by the results so far. Currently, we are in the continued access protocol stage of the trial. We are enrolling another 90 hearts. That's what FDA so far approved in order to continue the accruing of the experience and data. 37 patients were enrolled so far. We're hoping that may be extended depending on when the device is fully approved. In terms of the results, the continued access protocol so far, we're observing similar results to what's been observed in the IDE trial, the randomized controlled trial. Right now, this is a registry. At MHI, so far we had 5 runs for the DCD. 3 patients were transplanted. We have 75% utilization rate. So the numbers come from 4 runs with recovered organ, meaning 4 patients progressed to circulatory death, 1 did not. That's why we can see here 5 runs. So we had 1 dry run, patient did not expire, and 1 heart. This happened actually the night of Saturday to Sunday. Sami mentioned that 1 heart was declined after arrival at Abbott Northwestern Hospital for performance on OCS. 2 out of 3 patients required postoperative mechanical circulatory support, which means they were in grade 3 primary graft dysfunction. 1 patient was on BIVAD, was decannulated 16 hours after the implantation, and the second patient was on peripheral ECMO and was explanted after 72 hours to, in both cases, full organ recovery, normal biventricular function, which also was observed at other centers. Briefly in conclusions, organ shortage is still a limiting factor in the world of transplant. Deaths on waiting lists still happen despite different allocation system. Distance is a major obstacle, which means that extended donor criteria, warm, near normothermic preservation on OCS probably will be the future of the transplantation strategies. Definitely there's a big push and focus on more cooperative work between organizations for procurement and transplant centers that slowly are growing and will be probably the hubs of recoveries of the organ and allocating them in better, more organized fashion. I would like to really thank the foundation for allowing us to perform this research and leadership of Dr. San and Dr. Ekman, without whom obviously we could not do that. OPOs, LifeSource has been absolutely phenomenal with this trial. It takes a lot of effort and a lot of coordination and absolutely unbelievable amount of documentation work that has been done. They were very gracious with us. They're very helpful on site. They provide us with technicians. They provide us with expertise. They provide us with excellent communication between different OPOs. This is very important. Transplant coordinators, a lot of this work falls on them. I want to really highlight that It adds a lot of time to the nights, to the call time. Perfusionists absolutely mastered the device, and this is really a group of people that we have to acknowledge here. Right now, we transition to a technologist that is provided by the trial sponsor. However, they really keep an eye on the device, keep an eye of our disposables. They make sure that every run happens, that run that happens is successful, that we don't run out of batteries, disposable solutions, medications, etc. And really research coordinators that really keep our data in order. We have so far no failures in terms of the timing of the reporting, as well as the whole advanced heart failure team, which is very encouraging. We can see the paradigm shifting. I think that the transplantation is going to become more and more prevalent among sicker patients. That's why the whole allocation system was really changed, and why this is also why DCD, so donation after circulatory death, is becoming so attractive. Obviously, we know who does the heavy lifting here. Sami really mastered this device. I wish I had more time for videos from the runs, from the organs that we recovered themselves. He really does a lot of this work, and those trials are successful because of him. And this is really the ultimate goal for this trial, because nobody wants to do transplants on Saturday night. Thank you so much. I'll try to answer some questions.
So very quick question. So if the Papworth protocol is so successful, why isn't it being adopted here? The Papworth protocol is different. So is this a push from a commercial organization, which is Transmedics, or?
No, this is not an approved strategy of organ recovery here, meaning
Why not? That's what is the question.
So, yeah, they have two ways of doing this. So, what the donor after circulatory death, they are allowed, after the heart has gone through that 5-minute,
Sure.
they are allowed to try to resuscitate the heart within the donor after ligating the carotids. And so 20% of their DCDs have a resuscitated heart and a blood pressure. Then they go and do a procurement, and then they still use the OCS system and then do the transplant. In the US, to add that in, that is not a standard approach to
organ recovery.
Organ recovery.
You're right. I think one of the big difference in UK, and of course it's geographical as well. One is distances are short. The second is NHS has taken a very strategic decision for the last 50 years that every center doesn't do everything. So it's again focused in only 5 regional centers. Many things, pediatric, whatever, adult congenital, heart transplant, big aortic valve, so on and so forth. So do you see that as this gets more, this is very resource intense. So do you see this would happen eventually in the United States?
Yeah, it's a great question. The answer is it's possible, because there is a study that, Nader Mozami, who many of you guys know, is part of a study where they're doing DCD like that, with the exception of they're not using OCS. What they're doing is they're bringing and they've only done a few of them, they're bringing the donor into their hospital, allowing them to expire, ligating the carotid, and then resuscitating them, and then taking the organs. So that is starting right now. How these two may or may not merge is unclear, but that would be essentially what is allowed in the UK.
I think that big difference between the European centers and US centers is we do have decentralized health system, and I think that the decentralized system has its advantages and disadvantages. For better or worse, I think that the portable organ care systems will be more utilized than the stationary recovery systems because of the decentralization of the
And also
structure.
The geography of the size of our country is very, very different
Yeah,
too.
it's like entire Europe.
But this is going to be, the pitfalls of this technology were mentioned before. Cost, number one. Number two, expertise. There were many
That's right.
sites that started doing this that were unsuccessful in utilizing this because as you can see, as you can imagine, when we do a donor after brain death, it's a very controlled, you clamp, you throw it on ice, you close up, and then you go to sleep, and then you fly in the airplane back until you get up and do the transplant. There's no monitoring. Now, of course, during that time, you have no idea what's going on in the heart. But it's the labor, the concept, the technical aspects, and the management of that heart is essentially nil, right? Whereas the team, when they're out there is a lot of work. You're running an ICU essentially with this heart continuously throughout. And the benefits of that is that you actually have a pretty good idea, or at least we're getting a better idea of what the heart's going to look like when we arrive and whether or not we can utilize it. So we added those, but it does require way more intensity, way more knowledge, way more on management. And I think a lot of the places that had difficulty having successful outcomes with this was that the level of fastidiousness with which you manage these patients. The company recognizes that. They're smart enough to realize that they're going to need to have more skin in the game to make this successful. So they're hiring people to help manage these hearts as they're coming back as part of that next level. And how that's going to end up regionalizing some of the procurements for this potentially, which would be good for having a successful organ.
Last
Yes.
question.
No, go ahead.
No, it's the 6-month endpoint. Are you, means being in the transplant for so long, do you think you need a bit more or longer endpoint, or is FDA mandating a longer follow-up?
Oh, I think there's going to be
outcome?
longer follow-up, there's no question. I just think that, it's the endpoints of the trial. Now, rewind and say the expand part of it, that the donor after brain death with the expanded criteria, that data has already been submitted to the FDA. And the expectation is that if not, it's almost end of Q1, but probably within Q2, early part of Q2.
The last patient 6 months follow-up they will reach it in May. So we're hoping that this year it will be approved for commercial use.
For expand for commercial
For
use.
DBD extended criteria donation. Jay, what's up?
So say you have two hearts, one you accept, one don't. Is it just ischemia that lends itself to not being?
We don't know really all the answers, but what we definitely can measure on the device is the performance of the coronary flow. That's really what's truly measured, and what's the myocardium does with the lactate. This is really the measurable thing. So if you take all those hearts together from the EXPAND trial, from DCD trials, from basically all over the world, and you analyze those graphs of aortic pressure, coronary flow, aortic flow, and what happens with lactates, you can draw conclusions what the myocardium is doing, whether this is the heart that is going in the right direction or the wrong direction. And that's really what we see. If you put the heart on a device and you provide normal aortic pressure, which is about 75 millimeters of mercury mean, and you achieve coronary flow of 700 initially, you have lactates that very quickly start separating between the arterial and venous side, meaning the heart starts, instead of secreting lactate, start absorbing lactate or clearing lactate. You know that this is the first good step where you're gonna be interested in this organ, meaning this is gonna be most likely suitable one. And then you follow it. You see what happens with the coronary flow, i.e. coronary resistance over time. If the resistance suddenly starts increasing and you cannot mitigate it by infusing more adenosine, which is the maintenance solution, it's the relaxation solution for the vessels, and you cannot mitigate it by adjusting the flow from the pump, which then affects the aortic flow, it means that you're building up resistance in the coronary capillaries. And whether this is a result of ischemic injury, some myocardial process or myocardial condition that was in the donor that we're not even aware of, we don't necessarily know it. But based on the experience in humans and before, obviously, in bench research, we know that those hearts most likely will not perform well. And this is why we don't accept those hearts. But as you can see, the utilization rate is close to 90% across the board, and the survival 1 month, 1 year, and then in Papworth 5 years, 4 years in Australia is the same as DBD. So there's clearly those parameters that we're observing, whether they're complete and tell us everything or not, are quite predictive of successful transplant. So at this stage, this is what we know. We obviously analyze all those curves, all this data from the runs. But it is obviously we try to find physiological justification for it, but we don't know all the answers yet, obviously. So lactate clearance and the hemodynamic performance of the heart on the device. Those are the two main parameters of what we observe. The other thing is that before whether it's DCD or DBD expand, those donors go through a normal screening process. So those potential donor hearts go through the same screening process as any other hearts. So we obviously, check hemodynamics, coronaries in majority of cases. We look at echo. We know all those things. We know the downtime of the donor. We know the past medical history, etc. So we're not jumping into some, crazy space of knowing nothing. Those hearts that come our way are pretty much almost the same as we used, but now we getting rid of the distance problem, which is huge in heart, and this gray zone hearts that we would normally not take because they're not perfect. We only always went for perfect hearts before. Now we can expand it to the really gray zone.
Perfect, thank you.